Ready? That was my cue. Okay. All right. Well, good afternoon and welcome everyone. We're back with another CNE. For those of you joining us for the first time, welcome. For those coming back again, we're happy to see you. We'll be taking attendance at the beginning of this presentation, and attendance verification will be completed through competency testing. For those of you on Zoom, for those of you here, make sure you have already signed in so we can get all that information from you. If you're attending on Zoom, we will be sending out an eval form and quiz. You'll need an 80% or better to verify participation, and make sure you have added the interimeducation@gmail.com in your contacts. Please also complete the eval. It only takes a minute, and we plan our programming based on your responses, so they're very important. So please, please, please fill out those evaluations so we can improve. If you're attending in person, please make sure you've signed in, as I mentioned, and complete the eval and leave it on the table by the door on your way out. We'll be recording this session and posting it on our interim healthcare Topeka YouTube page. You may also view these again later if you wish, but due to the rapidly changing nature of the healthcare and practice interventions, please consider all recordings out of date 1 year from the original recording. Next month, we start 2 months of ethics CEUs. Each session will be from noon to 1:30 on Zoom. The first month will be on Ethics Review 2026 edition. We will send out a registration link later today. Without further ado, we're going to introduce a couple of our two speakers today. We have a couple dynamic and confident speakers, so I feel like we're in for a really special day. We have Anna-Marie Lauppe and Alexandra Heidebrecht from Astra Mental Health. Anna-Marie is a therapist with her license in master's psychology. She has worked with people from 8 to 80 for about 3 years in health center, community mental health center settings. Likes the diversity of diagnostic backgrounds she gets to see in CCBHC settings. Also teaches at Washington University as an adjunct professor in psychology. In her free time, Anna-Marie is the vice president of the board of Topeka Habitat for Humanity, spends time with her family, and loves to read anything exciting. As far as Alexandra, she graduated with a master's in psychology with a clinical emphasis and minors in substance use and youth and adolescence. She has worked with children in therapy, psychosocial groups, assessments, and therapeutic preschool. She has been working with adults since 2014, worked in community settings as well as with incarcerated individuals, worked for the Kansas Department of Corrections as a behavioral health professional for over 10 years, doing assessments, evaluations, crisis care training, individual therapy, group therapy, and more. Her areas of expertise are incarceration phenomenon, neurological issues, psychosis, and personality disorders. In her free time, she spends time with her husband and 2 sons, going on hikes, playing video games, and reading. So without further ado, our 2 speakers.
I've got so much stuff to hold. Hold the microphone. Okay. All right. Where do you want us to stand? This side, that side, doesn't matter. We're good? You're gonna be the holder? Yeah, you're gonna be the holder. Okay. Yes, we just skipped to the presenters page. We didn't stay on that one. We went to this one. Sorry, we're just trying to make sure that our online friends are on the same page. But while we view that, wonderful introduction. Thank you so much. I'm pretty sure that none of the things that I have on at least my block expand on that. I guess I do mention that I have specialties in assessment, anxiety, depression, and other mental health disorders across the lifespan. I did get my bachelor's and master's degree from here at Washburn, and obviously I loved it so much that I went back and I started to teach there as well. So we just have a good time there. Anything else that you want to mention from yours?
No.
Okay, cool. Moving on. So today we're going to cover with you some objectives. We're going to cover cultural implications of suicidality in the older adult population. We will also spend some time just covering for you guys what older adult means in the literature. It's kind of ambiguous, so we'll try to spend some time covering that. Some warning signs of suicidality or self-harm, pathways to suicidality in the older adult population, current treatments with in-practice applications, as well as treatment for the treatment resistant. And then, of course, at the very end, there will be time for you guys to ask questions, engage with us, and just let us know. But we do ask that you save some of those questions just for the end so that we're all kind of on the same page. All right? Okay, wonderful. We can go wherever.
You're Rome, I'm not following you.
That's fair. Okay, I'm going to stay right here then. She said no roaming. All right, to get to our definitions. So older adults, for the purpose of this presentation, we're going to use older adults as people 50 plus for the most part. There is some research out there that goes as low as around 40, 45. But again, this is not a set kind of like term, but most people start around the 50 plus age and then go up to anywhere else. So instead, the literature kind of reflects more on evidence to support cognitive decline as the aging factor. So once we start to kind of lose mental faculties, or we start to see that people aren't able to care for themselves in ways that they were originally able to, that's where people start to kind of define older adults. Suicidality. Those are going to be thoughts, actions, or gestures that could result in the loss of one's own life. And again, we're going to kind of minutia that out, get into some more details of that here in a little bit. And then self-harm. So two types that we're really going to focus on are non-suicidal and suicidal. Non-suicidal self-harm would be things like superficial cuts, bruises, or injuries that are not meant to cause catastrophic or deadly harm. And then suicidal self-harm would be cuts, lacerations, or injury that is meant to be catastrophic or fatal. And that can be complete or incomplete. So, cultural implications of suicidality in older adult populations is where we will begin. And here are some current statistics. So, about more than 47,000 suicides were documented in 2017, with 8,500 of those being in adults older than 65 years of age. Sadly, the actual number of late life suicides is likely higher than just those mentioned. This is because we can't always tell which ones that we can't parse apart the ones that were reported and which ones may or may not have been reported. A term that literature brings up is silent suicides. And this term includes things like overdoses, self-starvation, self-dehydration, and just accidents. So the idea here being that sometimes older adults find, for lack of a better term, creative ways to end life so that they don't have to make it obvious or make it painful for their family members to find them in those situations. Show of hands here for those of my in-person people. How many of you think that the odds of suicide decrease with age? Awesome, yeah. So it does increase with age, actually. So men in the 75 plus category experience the highest rate of suicides across the lifespan. A previous suicide attempt is the highest predictor of death by suicide, and over 70% of older adults who die by suicide saw their primary care provider within 30 days of their death by suicide. Doctors can play a really crucial role in suicide prevention by screening all patients for suicide risk, and that does count mental health professionals as well. So a lot of the time, and we'll get into this as we get further into the presentation, but helpful screening, empathetic care, and interactions can be what intervenes in those moments and really makes a difference for these folks. Suicide by older adults is also more lethal than by younger adults and adolescents. About a quarter of older adults complete suicide who attempt, whereas only about 1 in 200 young folk who attempt complete suicide, which doesn't seem likely because we hear more about the younger adults. But again, it's what's reported, it's what we know. This is an extremely large difference, and we're going to talk about some of the research reasons for that moving forward.
So this one is just an additional statistic from something that most people are aware of, which is the CDC. So the CDC tracks a variety of the things that they track is the increase in suicides in adult populations. Past statistics, things professional learns in school, previous suicide prevention programs, they all focused on population numbers and variables from that time frame. And the increase and rapid increase of the rate of suicidality and suicide in older adults has become quite concerning in the field. The problem now occurs that this group who had been previously overlooked and not specialized for, not included in the data, talking about like silent suicides, as we just mentioned, it's imperative that as we move along with the CCBHC standards for mental health specifically, we make sure that we don't exclude any of the groups across the lifespan. As it says, this is from 2024 CDC, which is people ages 80 and older had the highest suicide rates in 2024.
Yeah, and it is important, I guess, to note too, in terms of like the dates on some of these, that CDC and like, oh, the other big one, I'm blanking on it, but the World, yeah, the National Institute and the World Statistics, those come out about a year later. So that's why we're not seeing like 2026 statistics. Yeah. So here's some cultural factors to consider. Older adults tend to have more physical illnesses. It's not always the case, right? But as we age, obviously, sometimes our body doesn't do what we want it to. My grandpa's always telling me, hey, getting older sucks. Don't do it. And I'm like, Grandpa, I don't think I have, agency in that, but I'll try my best and stay young. They have more chronic pain along with that physical illness. They have higher potential for having experienced trauma in a lifetime. Existentialism tends to set in because like they're lonely, they're sitting around, they're not doing as much. And there's just some generational beliefs and stigma and Alzheimer's and dementia. So again, when we're constantly ill, we're in that kind of down state, it's much more easy for us to fall into a hopeless and depressed state. We see this a lot in the older adult population, again, in a CCBHC model, kind of like Alex was just talking about. We are supposed to see people across the lifespan. When you see people across the lifespan, you see people in different, hills and valleys of trouble. And so there are age-related troubles that come along with that. And the hopelessness and the depression for older adults does tend to come along with all of the physical illnesses and just being like, okay, well, I just had a surgery, I've got to have another one, right? And that leads into the chronic pain. So sometimes it's musculoskeletal pain, sometimes it's primary pain, cancer pain, post-operative pain, neuropathic pain, gosh, I can't say that word, and more. So this pain can lead to symptoms, again, of depression. It's thought to be associated with suicidality by the increase of hopelessness and the desire to escape the pain through death. They tend to think like, oh my gosh, if I can't make this better, if pain management can't make this better, what else do I do? Like, what other option is there? And so, again, it's a great time to intervene and be like, okay, well, we can do CBT for pain management. We can do these kinds of interventions that say, hey, it's not over. It's just a new journey. We've got to figure out where to move on from here. As populations age, the societal belief that events have effects that cannot be changed or erased kind of comes around. One such belief is the stigma of needing help for unseen pain or mental anguish that has been ongoing in the mental health profession. So we also are kind of going up against that. And with the older generations, a lot of time we are seeing that they're like, well, kind of stubborn about it, like they don't want to go. And it's like, well, you can try something new. Like this is just the same thing as it is like if you do have, a physical illness, you're going to go to the doctor, right? If you have a toothache, you're going to go to the dentist. If you're not feeling super good up here, we have a place that you can go for that. Let's try that first before we try suicide or another option in terms of like self-harm. And then the increasing rates of dementia across the globe have been associated with high likelihoods of suicidal ideation and attempting suicide. This group includes vascular dementia, Alzheimer's, Lewy body dementia, and frontal temporal lobe dementia. Sorry, that was a mouthful. But yes, as dementia increases, the hopelessness also increases, and it can be a very hopeless and painful experience to go through that as well. So, what are some warning signs of suicidality and self-harm?
So some definitions before we get terribly far into this. So there's active suicidality. Active and passive suicidality are different. I separated them for a reason, partially because of that, partially because of that silent suicide that we had talked about earlier. So active suicidality is having a realistic plan with intent to end a life. So this is the most talked about type of suicidality. It's sometimes also called acute suicidality, like with the CAMS framework, which we'll talk about later, while others may simply call it suicidality. So active suicidality really needs to have that realistic plan and intent to act on it to end their lives. And that is different with the passive suicide ideation, which is just having a desire or a wish without a specific plan to act on it. So passive suicidality could be, like we talked about with the silent suicide, this is, I don't care what happens to my life. I don't necessarily want it anymore. If something happens, I would probably do nothing to stop it. You might hear it in patients of, if a stroke takes me, just let me go. It doesn't necessarily mean that they're going to act on it or you have to care for them with kid gloves. It's just something to be aware of and to constantly work with. So then you have self-harm, which we talked a little bit earlier about, which is injuring self physically without the intent to die. There's a star there. The reason there's a star there is because sometimes, whether you want it to or not, it can end up in death. And it's because, like with the older adult population, like recovery rate has something to do with it. Ability to come back from a harm or for it being more deadly. Sometimes, especially in like overdose situations, they might have taken 10 Tylenol. Okay, so that might not be lethal to somebody, but it might be to you. So, sorry. And then nihilistic thinking, which is that pattern of thinking that life has no meaning or purpose. It's a numbness, a disconnection, or a hopelessness. If you've ever seen the movie It's a Wonderful Life, it's kind of a really good example of this. What would the world look like without me? Would anyone notice if I didn't come to work? Would their lives be better without me? It isn't necessarily I want to die, I want to end my life, or acting on any of it. It's just those thought patterns of what is the purpose? Why is it here? It's a disconnection. So some of the signs of suicidality in older adults could be specifically active suicidality is like saving up pain medication. These are different red flags that you might see with the older adult population. As we said earlier, older adult males are more likely to use lethal means when attempting suicide. It's usually not an impulsive, but a decision that was deliberate. A plan was made. Often making the plan or method so that there is no chance for rescue. They don't want to be revived. They don't want to be found. Older adults are less likely to use emergency interventions such as suicide hotlines or crisis services. This is important because going back to those generational beliefs, those stigmas, that wasn't something that was ever really a thing until what, the last decade?
Yeah, if you think about when 988 became popular, right? Like it's like, oh, you can call or text it. I mean, I don't know about you all, but again, my mom and my grandpa both are like looking at me crazy when I'm like, you can text a number. And they're like, why? Like, what does this do? And I'm like, I don't know. Like, it helps save your life if you really wanted to. And they're like, I wouldn't use that. And I'm like, okay.
So to go through some of them, saving pills, not taking them, forgetting them. Sometimes it is forgetting, sometimes it's not. So knowing the reasoning behind it, ceasing use of necessary medication.
That's a big one.
Specifically, I know that if I do not take my blood pressure medication, I will have a stroke. Vascular stroke, those are bad. But if they're doing it on purpose of I know what will happen if I stop. Increased attention to wills, talking to people more frequently than normal about now remember, and that's all that they ever talk about. That's a pretty good sign. Giving away possessions, again, outside of the norm. It's normal for people to make wills. That's not a bad thing. It's a bad thing when they impress upon it over and over and over in a short time frame. Saying goodbyes to people when they seem like they're doing well, health-wise, mental health-wise. And then you have passive suicidality. So these are signs that sometimes can be dismissed and happen at a pace that does not necessarily alert immediate concern. Avoiding appointments. So they used to be your regular client. They came in every other week to see you for arthritis or something else, and then they've stopped showing up, and they give you lots of reasons why they can't show up, but they start avoiding your phone calls, your appointments, ceasing medical interventions that are, especially if they're there to extend the life. There is a time and a place where everything is purposeful, but it just kind of depends. Sometimes they might blame transportation or feeling ill, but frequently running into, I'm not going to do this. Ceasing medical interventions because they are costly or they don't want to be a burden, or they don't have the time. Slowly cutting back on social events can also be a sign. No longer going to family functions, not inviting them to see them, kind of isolating themselves entirely. Also not engaging in community social events they once loved. So say that they went every Wednesday to bingo, and they stopped going. Or they have a friend group that they hang out with regularly and they stop because they're too busy, they don't feel well. Those kinds of excuses over a period of time usually are a pretty good indicator that there might be some concerns to have there.
Yeah. So here are some risk factors. Oh, I have to change that. Now we're here. Okay, so here are some risk factors, and we tried to kind of like put them to the opposite of like their protective factors as well. So some risk factors include like hopelessness, perceived burdensomeness, loneliness and isolation, being widowed, family history of suicide, loss or grief, loss of coping skills, and cognitive decline. So to go through those first, so perceived burdensomeness. In recent research, it's supported that suicidal ideation was found to be elevated when depressive symptoms were combined with the perception of being a burden. This leads to a new area of research and avenues of treatment to help lessen suicidal ideation in older adults. So nobody likes to feel like a burden. Nobody wants to feel like they're costing their family money, like they're, a burden to their provider even. And usually that sounds like, well, my family always has to take me places. Gosh, I don't get out of the house anymore because, I feel like my family's always having to come see me. And that sucks, or something like that. And so we have to remind them that like, you're not a burden. You're not a problem to be solved. You're a person. And those kinds of things. Loneliness, though technology has helped tremendously with remaining connected across distances, it does not make up for the in-person need of people to feel connection. That is 100% a social like need that we have. It's born into us. I tell people all the time, even if you were one of those people in COVID who was like, I was okay, just chilling without humans, like there was still like some part of you that probably needed at least to see somebody maybe once a month, because we do need that. This loneliness paired with other things on the list can reduce the effectiveness of interventions from professionals and systems set to help cope. So that's always something to keep in mind. they might feel lonely. They might feel like a burden to you as the provider. They might feel like they see you once or twice a week or once a month, right? And then you leave them and you're leaving them lonely. So these are all really important things to kind of keep in mind as well. Death, grief, loss. Life is not fair, and many have already learned that lesson themselves. It is not uncommon for someone as they age to lose loved ones, and each loss becomes a new battle scar to contend with moving forward. Though when you have collected enough scars that bone-tired weariness sets in and becomes a poison towards the vitality that pushes us forward. Um, I've heard this a lot from my older clients where they're just like, everybody I know is gone. And it's very hard sometimes to process that, but it's very important to process that grief and be like, yeah, I mean, I can't imagine what it's like to lose not only your family, but your friends and your support systems. How can we support you in this? Are there other things that we can get you involved in, to help with that? And then cognitive decline. In a study in the United Kingdom, cognitive decline was recognized as a significant risk factor for suicidal ideation and behavior, with many suicide attempts occurring within the first years following a cognitive decline diagnosis. And this can be via traumatic brain injury, Alzheimer's, dementia, anything related to that. There are protective factors, though. Hope is one of the biggest protective factors that we can instill in our clients, and just people we know that might be going through some of these risk factors in terms of like hopelessness or loneliness. Just
There
giving them hope.
is a story that probably a lot of people know, called it's about Pandora's Box, which originally was a pith, but I'm not going there. It's a story that one of my activity therapists used when I worked with her for years and years, that helped create a sense of hope, or at least understanding of the purpose of hope for people. And so, brief of the Pandora's box. Pandora was essentially a child god, and was given a box that had all of the emotions, negative feelings, and everything that would plague humanity. And what happens when you give a child something and you tell them not to open it? They open it. Of course, what happens? And so all of those things came out of the box and they went forward into humanity. However, the thing that was left in the box was hope, because hope would never abandon humanity. You cannot have your hope taken from you. You have to freely give it away. So when you explain it like that, it helps create a sense of like control and freedom for people, which is why it's over in that protective factor of why it's such a big thing for people.
Optimism is important. So seeing the glass as half full versus half empty, goes along with that hope. Spirituality, some people aren't religious, some people aren't really spiritual, but what we do know is that finding something bigger than oneself to believe in can be extremely important. Whether that is, I mean, I've known people who literally use like their grandkids or their family, right? Like that is their spirituality and their religion. They use that as their connection to this world. And they use that to move forward. So whatever you can kind of garner, again, that hope in and that strength in is good. Strong, healthy relationships. If you are the only strong, healthy relationship they have, then you're a strong and healthy relationship for them. That's really it. And we want to try to help garner more of those as much as possible. Social support goes along with that. And effective coping skills use. This one's kind of hard sometimes because they don't like to do it every once in a while, but sometimes it can be really nice, especially if you are a strong and healthy person for them, to show them how to properly use the healthy coping skills, because a lot of times we're not taught, right? Like we can't do what we're not taught. We can't do something we don't know. And so it's helpful if you are a helpful and influential person for that person to say, okay, this is how we do this. Like, why don't you try it with me? I know that, again, using personal like relationship with my grandpa, there are times where he's like, no, I'm not gonna do this. And he's like 89 and just stubborn. And I'm like, will you do it if I do it with you? He's like, maybe. And I'm like, okay, will you do it if I take you fishing after? And he's like, yeah. And so then we do it, and he's like, that wasn't too bad. And I'm like, okay, cool. And then like I find out he's doing it by himself later, and I'm like, see, we can do things, we can do hard things. So just kind of garnering that strength for people. So moving on to path to suicidality in the older adult population.
So there's a model in psychology that kind of looks at the measurement of suicidality by looking at stress, pain, and agitation. Being high in all three of these makes you highly likely to at least attempt suicide, if not die by suicide. By the way, politically correct, you're not supposed to say completed suicide, so you'll hear died by suicide a lot. So the thing is that what they also found in research is that if any one of those three things is treated, so stress, pain, agitation, the likelihood dropped significantly, making it less dangerous for people. Drivers, as we're talking about here, what drivers people have towards suicidality, as well as what motivates them to keep living, comes from the CAMS framework. Again, talk a little bit more when we get to the assessment. But it's seen as ways to focus on what is needed to help the person. So this is due to wide prevalence of like depression in the world. Just because you know that there's depression doesn't mean, sorry, it's moving. It does very little to actually help understand the suicidal behavior. Depression is prevalent, and people use the word I'm depressed all the time. It's a mood, not a diagnosis. And it's a normal thing. People can be depressed. There's reasons for that. So that's why a lot of this is focused on the actual driver for suicidal behavior more than just the words. The effect of hopelessness or having no thoughts of future on suicidal ideation is very important. Like I said, I talk regularly with my clients about the Pandora box just because it helps give an idea of what that really means. Generally, again, has a great response, and people are able to be a bit more insightful and aware. But another dimension of thought comes from self-hate and self-regard. So this is close akin to that. It's going to be a lot. Perceived burdensomeness. Here we go. This is especially important for the older adult population because as the body ages, I know, surprising, that comes with complications. So even with medical technology and all the other advancements that we have for comfort and functioning to extend, it's still going to be there because bodies age, they deteriorate. And until everybody turns into some sort of bionic thing, going to continue to be an issue. So I had a client who was an older adult who told me, if a time comes where I have to wear a diaper or need help going to the bathroom, I don't see a reason to live. That loss of functioning, that idea of self-hate, the loss of pride, having to ask for help, being vulnerable, those are all drivers that could be towards suicidality. Some of the drivers that we talk about to keep living, those are like what Anna-Marie said. Sometimes it's time with grandkids. Sometimes it's going fishing. One of my favorite things is I have people who they have some sort of unnamed collective where they all meet after they retire at whatever age, because you can retire as early as you're allowed, not necessarily with Social Security, but and they'll meet at McDonald's or some other restaurant in the morning and they just chat, which is great for motivation to keep living, that social connection that you have with people. So we talked about the paths of suicidality. It's important to remember that they're not all encompassing. So while people might fall into categories, there's always going to be outliers to these. So one statement that I believe is incredibly relevant and shouldn't be overlooked is predicting suicidal behavior has become a red herring that ultimately distracts us from the understanding and treating suicidal risk. If you look too much at the one thing and say, well, they don't have that, so they're fine, you're going to miss everything else.
The very can't see the forest through the trees situation. So current treatment within practice application. You get to do this one because you wrote all of that.
Yeah.
Sorry.
Okay.
I keep forgetting to press the button. And you
Buttons
can
are-
always yell at me if I do. So here we go.
So these are some treatment methods that are actively available. So one of those is peer support. It isn't just CCBHCs. I think there's a lot of different programs that have something like peer support. And it's very important because there's a difference between asking a peer, somebody who's been there, done that, been around it, than a medical doctor who you have deer in the headlights, that freeze up moment with. It's easier. Usually peer support takes place in the community, so it's also a safe place. They help keep people active. They help people get out and around and have some sort of sense of connection.
I have one client that this reminds me of, and is a success story for this. In late 60s, early 70s, and whenever they first came in to see me, they were like, I just want to be near the water. Like, I have to change my sound machine every time they come into water sounds because it helps calm them. And they're like, I just want to be near the water. And I was like, well, let's get you a peer support worker. So we got them a peer support worker, and now they go to the lake every time they can, like once a week with their peer support worker. Changes their entire mood. If they don't get to go, I know about it. And so it really is. It's a super imperative part of that specific client's treatment plan. So it can't be understated how much it actually helps with everything.
It also helps with the next one, which is family engagement or caregivers. So I know that this should not surprise anyone about how major this treatment method is for people, but I want to expand on ways to do it that are different than what most people probably talk about. I tend to be pretty humorous and I like games. And I call them games because people are more willing to do games than coping skills.
True.
So I call them games, and believe it or not, there's a better success rate of people trying it. And this is really great for family members, especially with grandkids and grandparents, but in general for the whole family. If you have never lost a loved one that is older than you, so the older generation, whether they were the grandparent or the parent, and you think, man, I wish I would have asked them more questions. I wish I would have known them better. So this is, sorry, my glasses are slipping. So this is the reason for it. So some of the games that I do with people who have family is questions. What if questions? So what if the whole world turned to water? What's our plan? Why? It's silly. Is it going to happen? I don't know. I can't tell the future, but I can tell you it's a silly thing that can get people involved. With my older adults, frequently it's we do the line of truth, and kids really like that. And it's really fun when the kid gets it right and the parent doesn't. Yeah. It also helps bridge some of those generational gaps between kiddos and their parents, because you never know the age gap between people. And being able to communicate better, really communication and connection at the end of the day. So maybe rewording things as games rather than duty, or coping skills or treatment plan. Less technicality, more
Homework.
fun.
They don't like homework.
So we also have outpatient therapy and inpatient treatment. There are 2 state hospitals currently, and a lot of crisis housing outside of it, across the state of Kansas and honestly everywhere. We're gonna specifics for Kansas. And so like they have inpatient treatment centers. That is not typically a place that people can go depending on how old they are, just because they are not medical treatment units. So they're also not good for some of that cognitive decline because those are specialty things that people may not be able to do. I know that one of the things that really frustrated and ended up having him retire was somebody had a knee replacement at my previous job. And so they had some metal in there. Well, it's not supposed to go off in the metal detector, but. And so you have to take off your brace. You have to do all of these things to be able to get through. And it's exhausting and you feel kind of targeted. So sometimes inpatient isn't an option for people. And so trying to keep them in the community with some of these other applications is our best bet. Activity and expressive therapies, I have an absolute bias for. I worked with an activity therapist for years, and I watched her change people from exceptionally depressed, cut off from people, isolated, family stopped talking to them, all sorts of things, back into themselves through groups, through art, through improv, which was a big thing, being able to act things out.
Through music.
Drumming.
Older adults love music therapy. They love it. I mean, and at our CCBHC, we do have an expressive therapies program, and actually it's recommended that if they have like the cognitive decline or like IDD, stuff like that, that we put them in the music program prior to art, because it's so well received. I'm not sure what it is. There's a whole class at Washburn on music in the brain. The brain likes music. Music does good.
It
Music.
activates different parts of the brain, and it helps it communicate between left and right. And
True.
so the more active the brain is, the better it is. If you don't practice it, you lose it, right?
Mm-hmm.
So case management is another one. In case you don't know what a case manager is, which I'm sure most people do, case management generally is just connecting to community resources, helping people see the resources they need, make individualized plans, instead of just large email blasts that everybody reads all their emails. But it helps not only with knowing what they are, accessing them, following up to see if it's helping, coping skills, using coping skills as it goes. Case management is really important because as you get older, you have to sign up for so many things. You get 600 billion emails. I think AARP starts now at like 40, but it's slow and it builds up, and that's a lot. That's a lot to have to deal with. Lots of forms, lots of paperwork. And if you are not doing well because you have medical problems, you have cognitive decline, or you're just really busy, doesn't help. Increased insurance services is really great. They have had they've had an increase in like what's available. For the older adult population, one of the things that I love is the 24/7 nurse line, because sometimes you have questions and you don't have time to go into the doctor, or you can't get there, or it's not safe, or you really just don't want to have to deal with the doctor because they're just going to push you off. Perceived feeling, I don't know if it actually happens. So sometimes it's really nice to have a backup plan. They also, your insurance usually specializes with what might be helpful. So as we looked at the lower end of the older adults, it will help start focus on how to continue good care, how to make healthy practices, and encourage you to do so. Different therapies that we typically use are like humanistic therapies, that existentialism, what is the purpose, what is the meaning? You are a person and you have worth. It doesn't matter your age. It doesn't matter if your knee works. It doesn't matter if you remember yesterday, because I don't remember what I had for breakfast. But it matters because you're a human. Dialectical behavioral therapy, cognitive behavioral therapy, which we talked a little bit about earlier. And then the systems of care for older adults. It's one of the great things with technology is that everything's online now. It's a lot easier to connect with people, keep all of your patient information in one place. But it does have the problem of, does everybody get to log in?
Right. And one other thing that we didn't put here, and I just thought about it actually as she was talking, volunteer work. And this is like a shameless plug because again, as you heard in my bio, vice president for Topeka Habitat Board. But our volunteer base is almost entirely older adults.
Jimmy Carter.
Yeah,
Sorry,
we do too at Habitat. But like, I mean, we wouldn't be able to build half of our houses without them. And honestly, they've told me several stories, just about how it helps them to feel like they have purpose, like they have something that they can go out and do, and they love it, and we love having them. So, if even you can get like your clients involved in something volunteer based, like that is a game changer for them as well, because that can become their family. So
I vote instead of big brothers, big sisters, we have adopt an older adult.
I'll think
That would be great.
I'll do that.
I'd learn all sorts of
Okay. Assessments for suicidality. So we've mentioned the CAMs multiple times. You're probably sitting here like, I don't know why they keep talking about this person named Cam. It's not a person, it's a thing. So it's the collaborative assessment for the management of suicidality. It's done by this guy named Beck.
Jobs.
Jobs. You're right. Beck is a different thing. That's CBT. Sorry, Jobs. And we do have all of that in the references section. But it's this longer suicide screening tool and assessment that really puts you in the collaborative role with the client. So the whole point of it is that you're sitting there side by side with them, being like, hey, okay, what are your drivers? So it has you rate psychological pain, it has you rate stress, agitation, self-hate, and then there's one more, hopelessness. And then it goes through reasons for living, reasons for dying. The big thing about CAMS that's different from a lot of other suicidal assessments is that Jobs is big on suicide's always an option, truthfully. As sucky as that is to say, suicide's always an option, because I can't physically control if you walk out of here and you choose to take your life. But what we're going to do is we're going to come up with a very comprehensive plan for how we're going to keep you safe from here to the next time you see me. We're going to come up with contacts. We're going to come up with resources. We're going to come up with ways to say, like, to control means. We're going to do a whole lot of work to make sure that this is not something that you choose to do. And it helps to let the client know that you're really with them. You're right there with them, and you're beside them in this journey. And then you do check-in sheets, and you have to get to a certain amount with a certain number before you're allowed to discontinue CAMs. And it's really great because you can actually show them their progress and say, hey, look, you were a 5 on psychological pain the last time we did this. Today you're a 3. That's really awesome. I'm very proud of you. And so it's a really wonderful measure in that. The Columbia Suicide Severity Rating Scale, pretty common. It's what we do at Astra. Every time they come in, they get one. It's really a yes, no, the first two. If you get a yes, you have to go down to 6, which is just saying, like, have you ever? Because basically it's, have you ever, or have you been having thoughts like fleeting ideations? Have you had thoughts of actually killing yourself? If yes, then you go down, or have these been within the last 3 months? And then you go from there. But again, it's meant to get a quick snapshot, and then you kind of move forward. The Beck hopelessness scale, you can check on how hopeless they are with that. And then, yeah, right. And then ask suicide screening questions, which is the ASQ. It's a 4-question screener that takes about 20 seconds to administer. Most of these, so the last three, the CSSR, the Beck hopelessness scale, and the ASQ are really fast measures. The CAMS takes a little bit longer. I was able to Google and find a CAM, like the CAMS, all of it online. So all of these, I believe, are actually open access resources. But the CAMS, it's helpful if you're trained in it. And it's helpful if you know a little bit more about it to deliver it properly, as well as to just.
It's also a great book because it's full of sarcasm.
Yeah, he is really funny. Which I mean,
It's better than a dry technical model.
it is true. It is true. And it helps to make it a lot more tolerable and digestible overall. So treatments for the treatment resistant, how are we doing on time? Okay, cool. We will wrap up. So, barriers to treatment, housing, services in urban versus rural, technological disadvantages.
I got this one memorized.
Okay, cool.
So housing is always going to be a treatment problem. As you get older, it becomes more of a problem. If somebody was living in a big house and everybody moved out and they now have to take care of the house by themselves and all the pets and the lawn, takes a lot. So then what happens? Do we downsize? Do we continue? That's somebody's lifetime home possibly. If they're homeless, it's hard. Homeless shelters are not kind the
No.
older you get. Luckily, there is specialty housing for older adults. Usually that starts at 55. I haven't seen much lower than 55. But some things there's wiggle room sometimes. So housing is also a barrier to treatment. Services in urban versus rural. So I originally am from a real rural area. There is hers is even worse. There is one treatment center and it's for 2 counties and it has 2 different places and luckily it's fairly easy to get to. They've grown, love it. But there is no like community center where they do any kind of activities. They don't have a parks and rec kind of thing where they get people together. Generally, in all fairness, they actually do the volunteer thing for like making costumes for plays in high school. We have a Renaissance fair, all sorts of things. But the services available is a lot. We talked about that peer support doesn't exist in the other one. Exists around big populated areas, including housing. Housing can also be a problem. Small place, bigger place. Technological disadvantages. I have this very beautiful phone. Great. I don't know how to use most of the stuff on it. I am not technologically advanced. If I could get away with having a flip phone, I would. But you can't, right? You have to have this app and that app, and you have to be able to log in and all of these other things. We have made it wonderfully forward with technology, but also people get left behind because they're hard to understand. And then you get the phone calls of, your loved one is now in jail. They need bond money. Please send bond money. Please don't ever fall for that. I talk with my clients all the time. Mobility and transportation. So this isn't just getting to and from somewhere. Sometimes it's the ability to get around with it. Like I keep talking about somebody who's had knee replacement, but I have people who have walkers. Well, if they have a walker or oxygen, I really hope that there's more than just stairs if it's a 2-floor building.
Yeah.
So, and then cultural practices. Different cultures accept and resist. Putting that back down. Accept and resist different things. It can be a problem to ask for help, to be seen as vulnerable, to lose that pride. So.
And then treatment resistant troubleshooting.
So attitudes is a big thing. What they think about the process. I talked about duty versus games. We also talked about spirituality and religion, getting somebody some sort of buy-in, some sort of meaning, some sort of purpose, whatever it may be for that person specifically. Adaptability to what's available. No, I can't do that. There's a water walking class in Shawnee Parks and Rec, and I always recommend it to my clients because 1, social interaction, 2, water. Most people like that. 3, it helps continue mobility, and it'll give you a group. Resource connections, case management, but also doing those resources. I'm a therapist. Technically, I don't have to tell you anything about Shawnee Parks and Rec. I'm not even from Topeka. But I know it and it's important, and I'm going to share that as they need it. So that's part of the professional's job, is to know some of these resources and be able to pull it out of their pocket when it's needed. Different motivators. I have snacks in my office. I also have water.
Yeah.
Because sometimes people are food motivated. I am too. And so I have people who will come. This is a lovely lady. She spends the first 5 minutes of everything picking out her snack. And then she has a great time. And then humility. And that mostly has to do with like the providers themselves. Remember that the person that you're working with is a human who is loved by others. And whether they think it or not, somebody loves them. So please treat people like humans. It's really important.
There's our references. I made them extremely tiny because I did not want to make 2 slides. We can always send out other references if you need them. Also, you can select this entire box and make it huge. Thank you. Questions?
Will you type your questions
you type-
into chat,
Yeah,
please?
type them in the chat. Type them in the chat. Type them in the chat. I haven't had the monster. She had the monster, and I'm.
This
Yeah.
is mine.
Do you have any tips or mentions to people that are in the incarcerated setting or working with a lot of people that have testified in suicidal ideation or
I love it. This is my thing. Okay. So, one of the best things that you do for incarcerated population, if they are already incarcerated, like I said, getting them involved in those expressive therapies is really important because arts in prison is a big thing. It is a huge thing, and it gives a sense of purpose. And I got to tell you, in the prison setting, mental health will always be beside you. That is something that we push and push and push and push. Mental health will always be beside you. Even if it's not a mental health thing, we're going to talk you through it. We're going to support you. We're going to do something. So recommending that they do different things. If they're worried about going to prison, one of the things that I tell people, which is humorous, is, hey, the healthcare is covered. Because that's a big thing is prison healthcare is terrible. Actually, it's really not. I've had people have all sorts of surgeries and procedures and care that they wouldn't have been able to do outside. They get dentures, they have new lives. I don't know if you've ever seen somebody who's lost all of their teeth because of poor dental care and they finally get dentures and they smile again, but it's a big deal. It's a big
really
deal.
good.
So getting them involved once they are there and before, just talking them through, this isn't the worst case scenario. Prison isn't what you think it is. It isn't what you see on TV. It's not that scary. And for what it's worth, there's a taboo in prison where you don't go after people who are older than you. Usually you get adopted and they call you grandma or gramps or something like that. So
You're welcome. Thank you for having us. Thank you for having us. Any questions in the room?
We'll wrap it up. All right. Well, a round of applause for our presenters today, please. Now that you did a phenomenal job of handling a really heavy situation and making it light, a topic, making it light. I appreciate that. It was good though. Thank you.
Thank you.
All right. Well, that concludes our presentation today. Thanks so much. Don't forget to get those evaluations turned in. Val will be sending out those on our interim education Gmail. And then I just want to plug our next 2 months. We'll have an ethics CEUs with the sessions going from noon to 1:30. So be on the lookout for information around that. In the meantime, have a great afternoon and thanks for tuning in.